Welcome, welcome. Welcome back. Always good to see you. And there's always so many of you, and it's always great. So thank you. We'll give everybody a couple minutes to sign in, and we'll get going. Hi, Wynette. Good to see you.
Hi, thank you, everyone. Nice to see you too.
Yep. Oh, and Tanya's there. Hi, Tanya. Good to see you.
Hi, everybody.
Yeah, we'll let you chime in towards the end. I have a slot open for you.
All right. Sounds good.
Yeah.
Hi, Tanya.
Hi, girl.
Look, all these people signing in. Wow, we have a long list here. That's great. And you guys know, all you guys signing in, you can put your name in the chat box and all the people with you, and we can be taking attendance for all the people who are also in the room with you, watching on the same Zoom. Great job, Juliana. Yes, thank you, Christian. Thank you, Shane. All right. Okay, so I guess we'll go ahead and get started, and I'm sure more people are going to sign in as we go along. But okay, so let's get going. So welcome to our Care Homes Echo. Next slide. This is co-sponsored, made possible by funding from United Healthcare, Aloha Care, University of Hawaii, and the GWEP grant from HRSA. And as you know, you get free continuing education credits from the convenience of your own home. We have the opportunity to learn from each other and to ask all your questions. So thank you very much. Next slide. And if we share any case presentations or examples, please don't share patient names or birth dates, and all your questions can be anonymous. And in fact, if you have questions that you might feel even embarrassed asking, although there's no such thing as an embarrassing question, you can private chat your question to Juliana today, Juliana Caldwell. If you want to wave and say hi, that's her. And just private chat.
Hi, everybody.
Just read your question out loud without identifying you. So that would be great. So it's supposed to be a safe place for learning and sharing, no shame or blame. And these are not official doctor consults. These are for teaching purposes only. Next slide. I think you all know how to use the chat box and enter your name and others joining in today, just like everybody's doing right now. I see all those great names over there. Thank you very much. And then there's a mute button, which I know all of you also know how to use, and keep it on mute when you're not speaking. And of course, we welcome you to unmute it whenever you have a question you want to comment. We love your sharing. Next slide. Okay, for this 4-part series for What Matters, we are on number 2, and it's about understanding what matters. We talked about who knows what matters last time, if you remember, with Dr. Fernandez and Jim Peach, and today we have understanding what matters with Dr. Karen Lubomir. Next slide. And you can receive certificates of attendance as well as CMEs and social work credits as well. There will be a, I guess John will put in the evaluation link at the end of the session. So then you can go ahead and click on that right away and get your credits. Next slide. Okay, just want to introduce our hub team again. I'm the course director of this ECHO course. And then Wynette is here. Say hello.
Aloha. Thank you for having me. Happy St. Patrick's Day.
Oh, yes, that's right. It's just in time tomorrow, right? And Maribel, is she around? I don't see her. Oh, Juliana is here and she's the one to private chat for questions if you like to.
Hi, everybody. Thanks for joining us today.
And we have Shane Anderson from United Healthcare.
Hello, welcome.
Oh, and I didn't even include here, we have Steve Balcom. He's also from Aloha Care and he's a behavioral health specialist. So any questions we can direct to him. And we have.
Hey, good afternoon, everybody. Happy to be here.
Great. And we have Dr. Karen Lubomir, and she will be our guest speaker today. She's also a geriatrician with our department. Okay. All right. So before we get started with that programming, I'm just going to do a quick few slides on COVID updates. Next slide. As you know, very happily, we're the blue line over there in Hawaii. And we are going down, down, down. And actually they stopped counting now. So we're not even posting it every day. Now it's just once a week or so. And so I haven't seen the last numbers. So there we are. However, I just want to tell you, please don't be complacent because apparently there is this new variant brewing in UK right now. And starting to spread around all over the US. But the biggest way to protect yourself is to get the vaccine and make sure everybody you know has the vaccine. The other update I wanted to give you is, next slide. As you've probably heard by now, Hawaii has this indoor mask mandate to be lifted on March 26th. 2022. So next week it's going to get lifted, I think next Friday. We're the last state to do so. But I just wanted to highlight the point that this guidance is for the general population. And it may not apply if we have high community levels of COVID. So Governor Ige stated that if we see another surge, we have to be ready to reinstitute the mask policy. So this is not, we're all done and we can throw our masks away. It's just for now because the counts are kind of low. And that's indoor mask mandate. However, the virus never changed, and we still recommend wearing a mask, especially in certain indoor settings, such as healthcare facilities and schools. All the public schools, all the private schools, all the schools, and all the healthcare facilities are still wearing masks indoors because these are congregate settings where a lot of people mingle and mix and still want to be cautious. And not to forget that we can still choose to be careful, especially when we are around people that we don't know. So if you guys are going out for dinner and, doing all kinds of gatherings, getting back to the new normal, you can, if there's people around you don't know and you have no idea what, who they've been in contact with, then please, you can choose to wear your mask. It's okay. And we should continue to encourage those who live with or work with vulnerable people to continue to wear masks. Next slide. Okay, and I just want to put in a word about socialization. It's been really tough on our residents, not being able to socialize freely with their loved ones, but we have to find a new normal. And with our counts down, this is kind of what CMS wants us to do, is try to achieve that new normal. But, the people we care for, our kupuna, are still vulnerable. They've been vaccinated and for the most part, and they're doing much better. They're in a much better position. But, I still want to even with the new normal, we still must screen visitors. Outdoor visits is still the best. Wash your hands, clean surfaces, and mask indoors, and maybe even outdoors, depending. And of course, socially distant, physically distant, 6 feet from other residents. So in the nursing home, for example, while families can visit closely with their residents, they are urged to make sure that they are quite a distance, 6 feet from other residents who they're not visiting with. And so trying to maintain some kind of distance would be great. And of course, don't tell people not to visit if they're COVID positive or if they're sick. And if they cannot comply and wear their mask indoors, then maybe they need to go outside or not visit. So, but I would encourage them to wear a mask indoors or go visit outside. And then, of course, there's questions like, well, can they hug their loved ones? I think way back we were reluctant to do that. But I think, you have to weigh the risks and the benefits, and perhaps doing that with the consent and of the resident and the family member, knowing the risks, that is fine as long as it's with their own loved ones and not with other residents in the facility. And then sharing meals, well, anytime you take off your mask, you always run that risk. So, maybe outdoors would be great, picnics, on the lanai, do it something, but please socialize, but do it safely. Next slide. Okay, and I just want to, this is actually from last time as well, refer you back to the nursing home visitation FAQs, the frequently asked questions. There's a link over here, and I'm gonna put it in the chat box a little bit later, but those are the guidelines for that, the updated visitation FAQs that should probably apply to care homes as well as nursing homes because of the vulnerable population. So, okay, so hopefully that will be helpful, and everybody will be able to continue. Send it over to Dr. Bamir, and she will talk about our topic, what matters.
Okay. Thank you. Thank you, Dr. Wen. Thank you for the update on COVID, those ever-changing criteria and minute by minute it used to be. Maybe we have a few weeks of reprieve in between before they change things again. But thank you for inviting me to speak, to join you in what matters, in the 4Ms, or how do we provide age-friendly health care. This is near and dear to my heart as a geriatrician, and I provide also a lot of palliative medicine care for a much older population. I'm actually, my clinical side is at the VA. I may have run into some of you in either coming to the clinic, or I also do make home visits with our home-based primary care program. And in order to have entrance into our home-based primary care program, you need to have an illness or condition which makes it very difficult to leave home or very difficult to monitor in a clinic type setting. So we make a foyer into the home. And what I particularly find, I was just counting up my patient age population, and most of them are well into their 90s. So this topic becomes incredibly important. They bear a huge burden of illness. They bring a variety of lifelong experiences, and not all of which they can tell me about, and not all of which they can tell you about. So trying to understand what matters most as we attempt to provide the best care and support for them is of critical importance. And I always come to, when you meet somebody for the first time, understanding whether they're first time resident in your home, or maybe there's been a transition in what's happened in their healthcare. We want to understand at this new juncture, what matters the most to them as we look. I love this little diagram that somebody made where you have looks like healthcare provider on one end of the scale and the couple sitting there, and maybe they have a heart ailment or something from this picture. But, there's always choices to be made. Whether it be medication, treatment, therapy, no therapy, which direction we go. And while we have all this technology in medicine and all these things available to us, how do we know what to offer? It's not like a menu where you say, oh, I'll have one of those and not one of those. First there's a burden of cost for that. There's also the burden of just going through those procedures, swallowing that medication, managing the side effects. So we really want to know what we're doing is what aligns with that individual would want, what matters the most to them. So how do we even start having that conversation? Next slide. So one thing is when you first meet somebody, or somebody becomes a resident in your home, or you're having an encounter with them, how do you how do you start these conversations? Why are they so hard to have? You know, I'm just meeting you for the first time, or you're just meeting them for the first time. What makes them difficult? Does anybody have any experience with this?
Don't be shy. You can chat in the chat box. Or you can just comment. Cultural differences. Yeah.
Yes, thank you, Juliana. Yes, so they come with an entirely different set, maybe from something that you're familiar with, that's acceptable in their culture versus, you know, the current Western medicine culture, and they're afraid that they're not heard. They maybe have not been respected for that. There's a lot to be said for that. We don't always allow in Western medicine influence of others, of other cultures. Dr. Wenza, they may feel offended that you're even bringing up. Maybe this is a topic that is sort of not spoken about. We don't talk about death and dying or what the end looks like. Oh, I like that, Juliana. How do you even start this? Hard to make rapport with somebody that you're just meeting at for the first time, or if they're not able to speak for themselves, maybe they're family members. You know, it's hard to break into some of those situations. Perhaps they've experienced poor care if they were in a different different facility, maybe a nursing home. They could feel very vulnerable at this time. They're feeling ill, they're not at their best. They feel like they've lost control. So hard to have that. Well, I see some chat. I can't see what it says. They don't know you. So why should they tell you these kind of deep innermost thoughts that they have? Why should they share that? Also, you may be seeing them just one time. And so what impact does that make on what's going to happen in the future? How can they assure that what they tell you is actually going to be enacted upon or respected? Let's not forget about ageism. And fear that, you know, that they won't be provided the care that they desire. Or like Dr. Wen just said, maybe they've had a family member that it's not gone well and they haven't been respected for what matters most to them. And people went forward down a treatment path or something that didn't respect who they were. Next slide. There's also another piece, something called trauma-informed care. And I bet Stephen could speak a lot about this, but just a few core principles that everybody brings a story. One of the reasons I love geriatrics, I love the stories. I mean, again, I keep saying veterans, I'm sorry, that's my frame of reference, but patients bring or residents bring their life experiences with them, all the things that came in. We don't really know what those entail. Sometimes we hear snippets from family, something may come out as you're providing care for them in your facilities, but there's some core principles, and these 6 are here illustrated for you. People have to feel safe in order to share, in order to receive the care, make their needs known. There has to be some transparency that go on to build this climate of trust within the providers or within the organization and those receiving the care. There's some principle of peer support, and that's what you see the idea of support groups, either within the organization or more informally. There may be groups that can get together as well. I know at the VA we have a number of peer support groups across the board for sexual trauma, sustained during the military, for different PTSD and and the like. And then we have different conflicts had their own different. What can I say? They had their own kind of culturally a little bit different, or they were like Vietnam veterans are a little bit different than World War II veterans or Korean War veterans. And there might be something a little bit similar that they can relate to with each other and support, or their spouses in some cases. Another core principle is collaboration. There is, sometimes about this sort of hierarchical or power difference that has to be addressed, so that people that has to be a little bit equilibrated, so that can be shared or supported decision-making in looking at plans going forward. Persons have to feel empowered that what they say matters, it's validated and recognized, and so that tries to sustain that climate of or ability to heal from the trauma, and that they can become more resilient to it. And lastly, humility and understanding that there are biases and stereotypes. And there's listed a number here on this last corner where it could be race, ethnic, sexual orientation, age, or what the historical trauma is. And we need to be humble that we might not understand it, but that we seek to understand it and then respond to it. Stephen, do you have anything to add here? I imagine that I'm putting you on the spot. I apologize. If not, we can keep going. All right. Next slide. So what is trauma? Just because we call it trauma-informed care, it could be any of these things I just mentioned before. Something that caused some physical or emotional threat that's lasting on that individual's well-being far after the trauma or the event occurred, I should say, or the series of events. So individually, as I mentioned before, it could be physical, sexual, or emotional abuse, natural disasters, regional events. So maybe local events within a community, upheaval, leadership change that devastated the community, loss of religious leaders, something that was felt across the region, or then also cultural group, which we're seeing right now, right, with Ukraine and Russia, that there's, I can't imagine the trauma that's occurring over there at this time that will reverberate through that community for a long, long time. Somebody, the person who helped make the slide, put in something that maybe all of you are familiar with, the middle square with the emergency alert that happened several years ago where somebody pushed a button, right? And we had this however many minutes of terror that we were under attack here in Hawaii. Next slide. So how does, why are we talking about this? Well, trauma does affect health in this ACE study, or Adverse Childhood Experiences study, which looked at the number of traumatic events that somebody experienced prior to age 18. They received a higher score. And what is that higher score? Over 4. I'm not going to look at the study, but we just know that it had effects. And some of the effects they were seeing that affects health later on would be they're twice as likely to smoke. They're 4 times as likely to have emphysema or chronic obstructive pulmonary disease. They're 7 times more likely to self-identify as having a problem with alcohol, use of alcohol, 10 times more likely to have injected a street drug, and about 12 times more likely to have attempted suicide. So as you can see, that this can have a profound effect on people's longevity and overall life experience and how they interface with the healthcare system. Next slide. So the recommendation, because you don't know, and perhaps the resident that's living in your facility is not able to tell you that, and maybe they've never told anyone. They've never told a family member. Either shame or blame or guilt, or just had such trauma from it, they couldn't tell anybody, maybe not even their close, their intimate partner. So the idea is to always use this trauma-informed care, universal precaution. Next slide. Advance the slide. John, please.
John, can you click ahead the bullets?
Yeah, it's going to come up bullets. Sorry. Does it come up? What happened to all our bullets?
Oh no. Okay.
I animated these slides when I got them. So whoops. Well, I'll just, oh, is he animating for me? Sorry, sometimes that doesn't happen. Well, just think of universal precautions that you do right now. So when you do universal precautions for infectious disease or potential infectious disease. So, or if you are providing care for somebody that you don't know, or perhaps have cognitive difficulties, or you're just meeting for the first time. I mean, first thing you want to do is set the stage, not be in a rush, to approach the topic, or whoop, there he goes. There he is. Okay, we're going to go do away with the bullets. There we go. Oh. So first thing to do, would be to inform the patient who you are and what you're going to be doing with them. So if you're going to be talking about, what matters most, or you're going to be providing some hands-on care, whatever it is, just who you are, what your role is, and what the purpose of what you're going to be doing. You can't be rushed, especially having these conversations, exploring deeper emotions or deeper feelings and what matters most. You need to take time. Be aware of your body language when you're approaching and your facial expressions. Make sure that people can hear you. Noise levels around you are low. Avoid being authoritarian. Really, let's work on this together. Creating a collaborative approach when you're communicating, inviting questions. No blame, shame, no judgment when they're telling you what matters and what they've gone through and how that impacts what treatment that they're looking for. Try to not ignore what their needs are, however it may seem trivial, but looking for solutions in their desires or what matters to them. And then helping them identify strengths and building on those, what they can do, what they have control over. Whether it be filling out their post forms, whether it be filling out the menu, whatever choices there are. If something matters to them, what they have for breakfast every single day, if that's what matters to them, that would be important to signal in their care plans. Next slide. Here's a question. So this already came up. So what makes a person who they are? And I talked about it's the experience that they bring, how they identify themselves, the culture which they grew up in. And I'm not just talking about ethnic or racial means, I'm talking about the culture. Did they grow up in a more nuclear setting, or the nuclear family, or they're very isolated? Did they grow up with large extended family with shared decision making? I mean, what are they bringing to that relationship? And that's over time. That's where that universal precaution comes in. We want to spend time getting to know them. What relationships are important to them? Who do they identify that supports them? And how are those explored? What's their underlying personality like? Their likes and their dislikes. Can they express that to you? And these are things not going to happen in a single conversation. You have the luxury, I would call it, of time to get to know the residents that you care for. Next slide. So if they trust you enough to have the conversation, be mindful. I think Juliana said, be mindful of how culture will be affecting them. So here's a checklist out of Age-Friendly Health Systems toolkit in identifying what matters most to older adults. So the first one, and I'm not sure, are these animated, John? Because this is a really busy slide. Yes, it is. Yes, I did this. Okay. So the first thing to do is, how does this person identify, what's their preferred term for identifying their cultural identity? Be important. Next. What's the formality? How do they like to be addressed? And if they can't tell you, maybe their loved one or their family member can tell you, what degree of formality is it? Auntie, uncle, Mrs. Where are they? And so that will help generate some trust, and they feel that they're being respected. They determine what their preferred language is. This may actually require interpreter services to get to, so that they can communicate in a language that's comfortable for them. The next one is be respectful of any nonverbal communications. This especially comes up when we have body language, so that's gesturing, maybe misinterpreted because it has a certain meaning in one culture versus another. So watching your own body language or body language that they may be expressing. Are there any issues related to culture? Really, at the university, we're really actually being schooled on this and infusing this into our curriculum, looking for areas that are linked to cultural past sort of injustices, if you would say, because there's a lack of trust. They fear medical experimentation, maybe they fear side effects, or they're unfamiliar with Western belief systems. If you get the chance, really an in-depth review of their medical records, because there may have been this history of trauma that's recorded in there. We want to know who they are. Are they have refugee status? Are they survivors of violence or other actions? And these are extremely sensitive issues, and they may come out slowly over time. There's really reassuring that whatever they tell you is confidential. Next thing is to understand, just because somebody has lived here, X amount of time, what's the level of acculturation? What that means is, are they a recent immigrant, or maybe not recent immigrant, and they've held on and they've said, no, we're not going to accept this. We're now living in Hawaii, but I'm going to hang on to practices that I had in Somalia, and I'm not going to ascribe to that. So really understanding how much they've acculturated, or how much they've accepted whatever the norms of their current living situation is. Recognizing health beliefs. Again, these may include alternative therapies that need to be explored as you offer, understand what matters to them as you look forward to treatment or care options. Next one is how gender or gender identity may affect their decision making, and being able to explore. Again, I think those are all incredibly sensitive, or can be incredibly sensitive topics. The last one is incredibly important. We all, Western culture is like, it's really individualism and, I'll take charge, I'm in control, versus they may come from a culture that has more shared decision making. Maybe the eldest son is now tasked with making the decisions for the family, and that's the one that needs to be included in the conversation, what matters. And the resident may keep deferring to that individual. Maybe it's a collective group of shared decision making, not just outside sort of a more nuclear unit. Maybe there's extension that we need to take into consideration. Again, this is a very long list, but this is really trying to consider the individual in entirety. Next slide. Okay. So what do I even say? Where do I start? And actually, in the medical students that we work with and residents, we have some of our faculty that are very good at just getting these conversations started. And some of these things, some of these questions come to you today from that. So if it's on a daily basis, like what's important today? What makes them happy? As you get to know your residents, you'll automatically be able to say some of these things. But in getting to what matters most and how you're going to plan out the care and the days and treatments for individuals, what brings them joy? Ask them what makes you happy. And you may need to be somewhat of a detective to get to this. Are there things that they're worried about? Because that may impair their happiness or their ability to enjoy things. And are there any goals that the resident or their family members would have for themselves over the next 6 months, or use something like before your next birthday? What would you really like to accomplish? Also, looking ahead, day by, what's tomorrow bring? Just asking, is there something that's important for me to know about you, in order to help, care for you? And then let's say it sort of deals with health literacy. And that's like, how does somebody learn the best? For people that have not, don't have a lot of education or a high level of education, actually verbal is much better. So listening or watching a video may be much more tolerated than handing somebody reading materials. So that might be a way to get at some of these issues. Next slide. So after we've kind of understood what matters, sort of those core ideas for people. How do we then take what they've told us and how do we marry it with what are the treatments that we may be offering or the daily activities that we may be offering? So, and because we're in healthcare, we're talking about health. So what do they want to focus on? And what are some future goals, as they look at their health? And what are their fears and concerns for your families? Because if they're have a family unit, they may be concerned about being a burden or something else that you've unmasked. So or there may be a financial burden. So that needs to be explored. Another question would be, are there important goals if your health situation worsens? Again, in geriatrics, usually we're dealing with later stages of disease or illness and things progress. So asking, how do you enjoy every day to the fullest, even as the situation declines, health situation declines? Can we make modifications to help meet these goals? Another question might be, what about healthcare? If you think, is there something that are we giving you these 27 pills every day? Is that really helping you? Is it bothersome or difficult to swallow them? Are you on so many medications that you don't feel well or up to doing those things that matter to you or meeting those goals? So exploring that. And lastly, is making sure that you include, as I alluded to before, it may be a shared decision making. And they include family members or others in that, or a significant other in the conversation. So having that person participate, especially if the individual has cognitive issues or dementia, and they can't express themselves, you might want to include that person in the conversation. Next slide. So who can start this conversation when we look at planning? Well, the patient, and family members, caregivers, physicians, anyone else on the interdisciplinary team. So nurses, social workers, pharmacists, activities coordinators like recreational therapists, even, housekeeping, that in hospitalized settings, sometimes they find out things that the patient hasn't told anybody else, or the person delivering the meal every day. Oh, care home operators, Anita said, Dr. Wen said. Yeah, but anyone can initiate this conversation. The thing is that how is the conversation going to occur? It's with someone that's making them comfortable and has really the time and the availability to explore all this. These are very in-depth and can be emotional and definitely time consuming. And as I said before, it's not going to happen in one session. If you're in an emergency situation, perhaps. But otherwise, there is a luxury of time that you can start these conversations. Excellent. And so when should we do this? And when do you have to revisit? Well, upon admission to your facility, needs to start, you want to get to know this individual, or at an annual visit, we might re-explore this, okay? So, or an annual review would be a good time. So at the physician's office, if they get a new diagnosis, very important time, okay? Especially on the weight of the diagnosis, if it's a cancer or a new heart failure diagnosis, something like that, we should revisit, okay, now what matters? Because we're at this beginning of this new chapter. Also, if there's just a change in condition or chronic disease progression, so heart failure is worsening, kidney disease is worsening, liver failure, or liver disease progressing, really good time to stop and say, let's reassess, what matters at this point. And again, some of those questions from the last two slides, very important or helpful. And then inpatient visits, if you're actually admitted to the hospital, depending on your condition and situation, needs to be revisited. What would what matters at this point in time, looking, with what's going on right now. And these are things sometimes on admission, the team will admitting table ask about things like, if your heart were to stop, if you were to stop breathing, where are we, what would you like done because, you know, this is your underlying condition. Next slide. How do we share what matters? Because we've had this conversation. This is completing documents, making sure we have, if the person can't speak for themselves, that there's a durable power of attorney for healthcare. That's DPOA, HC is healthcare. That they have an ACP or advanced care plan in place, or a PULSE, providers ordered life sustaining therapies. That's a place, that's your green sheet that you all know. Making sure the conversation is documented in the electronic medical record, very important, because that can be conveyed to other people participating in their care. It should be discussed with the care team, especially when there's a change of condition or an admission. It should be, for you, it should be definitely incorporated into the rest of the care plan. So that can be first and foremost. And then having a continuing the conversation. You may, as you get to know somebody, you know, as a physician, as they get to know people, things are uncovered and the situations change. So the conversation is ongoing. Next slide.
Okay, I'm gonna kick in over here. But before I go on, you know, I just want to ask people, I know that oftentimes you just let the doctors do this job, right? Or maybe the case managers can do this job. Have any of you tried to talk to or found out what matters to patients? Anybody? Want to just, you know, raise your hand or just say yes somewhere on the chat
Yes.
box? Yes, you have. Anybody
Yes.
else? Yeah, Juanette, what was your conversation like?
Well, basically, I asked them if they had the conversation, an open conversation with their family. That's how I engaged the conversation. And according to my resident, she said that she spoke with the children and the children were having a hard time helping her make the decision. So till this day, we have not. So she's full code.
Okay. Yeah, and Ruby also says yes. Is there something you want to share about that?
Can you hear me?
Yes.
I recently had one of my family members, we're kind of having a difficult time about putting her husband on hospice. So that was kind of a challenge for her, but she only decided to put him on limited, the limited care, I guess, whatever it says on the post. So she's kind of having a hard time, but he is a DNR. So
okay. Yeah. So, you know, this is the thing. So the doctors may have the conversation, case managers have the conversation, but it's important that you support them in that too. And that's why I find that a lot of nurses or social workers or care home operators, you know, it's important because people are gonna flip flop and change their mind and feel iffy about things because these are really super sensitive. They may feel guilty or whatever. It's really important to just listen to them and figure out what it is that's causing them hesitation. And those kinds of things that you find out when you're just talking in the middle of the, you know, evening and on a Saturday or whatever, and they just say something that surprises you, maybe you can share that, you know, and say, you know what, I was just talking to her and it seems like she's had enough, you know, and this is too much for her or something, or she really wishes something else. You can share it with, you know, share it with the case managers, share it with the doctor and say, hey, I found a little nugget of information, and I just want to share that with you. So when you have the conversation, it might be easier. Yeah. Oh, it says, yeah. So Juliana says it normalizes the conversation if everyone talks to them. Yeah, it's true. Right? If you're a caregiver, can I sign? Of course, I want you to. Yeah, we should all have our own advance directives and sign our own. Yes. Let's not forget ourselves. Yes. Yeah. Well, you know, if case managers are great that's great, but it's also helpful. It's just about getting to know people and sharing the information. So you don't have to share the details about all the medical details. That's too complicated. But finding out what's important to them and what gives them, what worries them, are really important for you to share. Ah, yeah, that's good. Yeah. So any other comments on people who tried to talk about what matters with their residents? I really love it when other people share, especially the caregivers, because they know a lot more than we do. And they have good input. So that's really valuable. Yeah. Okay, so just going back to checking the chart, hit next slide, John. So yeah, so number one, making sure they have that general power of attorney, that they've designated somebody, their relative or their friend, to act on their behalf when they cannot. And then number two, the second thing to look for is their advanced care planning, where they decide what types of care they would or would not want. And then there's number three, is that provider order for life-sustaining treatment, the green post form. So there's three things to look for in your chart at your facility. Next slide. And so, yeah, so as last time, Michaela is going to send you a link to fill out an online survey to share how many of your residents have these three documents. So do they have power of attorney? How many of them have it, and how many residents do you have in your facility? So if 5 people have it and you have 7 in your facility, then that's 5 and 7, in terms of if they've designated somebody who could speak to them, right? For example. And try to have someone screen all your residents before our next session. And if you've done it already, fantastic. And if you haven't, give that a try. We'd love to see if we're making a difference and getting the numbers up. So do your best with that. Next slide. And yeah, and as we provide ideas to help your residents and families complete these, including you're having conversations in a very sensitive and trauma-informed way, give these ideas a try. There's no downside to it. Just give it a try and share your experiences and see if we can all try to do that. And we're going to ask you to do this again at the end of May when we finish our four series on this, what matters. And this will help demonstrate that you guys are doing a good job helping the residents achieve their wishes. So that's what we're trying to do. And these are Michaela's office hours. Michaela's not here today because she's actually on vacation, but she will be back on Friday, this Friday. So she'll have office hours at 10 and 1. And on Monday, the 21st at 10 a.m. And you can always email her like you always do each time. Next slide. And I just want to there's just a couple of other resources to help with having these discussions and things like that. And next slide, including the deciding what if these are books that I think some of us have requested, and Michaela has dropped off at your places. And if you do want a copy, we do have a bunch available that we can provide for you as well, to let us know if you want it. Next slide. And then just a few toolkits. Some of the slides that we showed you earlier are actually from the Institute of Healthcare Improvement Age-Friendly Health Systems website that talks about all the different ideas and suggestions. And these are other tools, and they each have their own websites where they have different ways of having the conversation. call it a conversation because it's not, we're not telling them what to do. We're sharing and we're working together. Next slide. Okay. Anybody else want to comment on how they're feeling about talking about what matters?
Hi, Dr. Wen. This is Juliana. If I may add just a little bit, I've spent a lot of my career promoting and advocating for advanced healthcare directives, as my specialty has always been pain and palliative care and end-of-life care. And one of the, the Kokuamau has amazing resources, and they've been a part of my foundation for that knowledge, including the Conversation Project. It's a great way for people to just even think about having that conversation. And I know a lot for the providers, or for those of us, the care home operators that are providing this information, it's scary kind of for us to talk to them about it. And one way that I've always had success in approaching it with our members and with the family and having that conversation together is I ask the member or the patient, think about your family, because they're the ones that are going to have to make these hard decisions when you're unable to make these hard decisions. And if you have that in writing, it makes it so much easier for the family to do that. Lots of times there may be multiple siblings, and one sibling's view may not be the same as the other sibling's view. And by having this, and by having our member or our patient fill out what their wishes are, it makes it patient-centered is what it does. And it also takes the pressure and the burden off of the families to have to make those decisions as a family. And I noticed that at the end of life for many of my patients. And that's what the struggle is. It's already hard enough that it's at the end of life, and then to have the family fighting over what that end of life is going to look like for that patient makes it even more stressful. And to have it in writing what that patient wants makes it less burdensome for everyone, and it gives them the dignity in death. And I think that that's really important to think about when having these and when having this conversation. And I hope that's helpful. That's just from my experience.
Oh, thanks.
Thank you for letting me share. Thank
you. Oh, the link to use at the end of the meeting. Oh, I think, John, if you could post that up again, then that's the link to get the evaluations in. Okay, Alzheimer's Association has an announcement to make, so I'm gonna let Tanya chime in here.
Hey, everybody. Oh my goodness. I tell you what, you guys, I know you guys have a lot on your plate, and we have been thinking about you over at the Alzheimer's Association. I have experience in long-term care and kind of what that looks like. So wanted to have a support group for you guys to just kind of meet and just validate each other, normalize your situations, or even just giving you some kind of resources to help what some of your major issues might be with folks that have dementia, because we are Alzheimer's Association. But just wanted to share that, and I'll go ahead and.
You're mute.
Oh, did you hear me before?
Yeah, and then you suddenly muted yourself.
Oh. I'm trying to enter what I'm trying to, it's actually on the chat, but it won't, when I press enter, it mutes me. Oh, there we go.
Oh, there it goes.
Okay. Yeah, it didn't mute me that time. I tell you what, technology too has been a learning curve for everyone, I'm sure. So here are, if you can see in the chat, you can see the two times that we have. We have 10 and 2, and you can actually copy and paste if you want to do it that way. However, we are going to have a flyer. So we'll be sending that to you by probably Wynette. We don't have your email, so either Wynette or someone who has your email. But yeah, these are going to be two options, because I know you guys have different times that you can meet. It's going to be on the 31st. We're going to have breakout rooms. We're going to have, because of we're anticipating a whole lot of people. So we want to make sure that everybody is able to have their needs met. And so that's why we're going to do breakout rooms each time. So there's going to be four breakout rooms, and more if we need. We're going to try to get more. So excited about that. I wanted to just kind of put it out there. If there's a place, I live in Kapolei, I don't really want to drive all the way downtown. If there's a place in Kapolei that is a care home, I would love to visit and just kind of get an idea what it looks like. Like I said, I'm from long-term care, so it's different. It's a different feel for me because there's like 94 residents. I know that you guys can have up to 5. And yeah, if there's a place, I'd love to just visit before the care home support group, so I can kind of get an idea better to better help you guys. So yeah, we're just looking at just different ideas, and we've already got a couple in mind, and super excited. So hope that you guys would be able to make it. So thank you so much.
Thank you, Tanya. I'll definitely get in touch with you. We have many members out there from ARCA in the Waipahu area, Kapolei. So I'll get in touch with you. And I look forward to seeing you. Thank you so much. I understand you're going to represent for us on June 11th. Thank you so much on that. So looking forward to that also.
Yes, I'm so excited. So excited that you asked us to help, and just want to, I'm a social worker by heart. I'm a counselor. I just want to help people. So I want to make sure everybody's getting their needs met, and talking about trauma and those type things in that last presentation. I mean, there's so much of that we have in our own lives, and when we're trying to help people, it's definitely hard to help when you've got things in your own life. So excited to help you guys.
Great. No, I really appreciate, your willingness to have a support group. And, there's so many people out in the community have a support group with you guys, but, care home operators, they deal with so much, and it's so important. So thank you. And yeah, and don't forget, have a happy St. Patrick's Day. Eat corned beef and cabbage and dress in green. So may you always have walls for, may you have walls for winds, a roof for the rain, tea beside the fire, laughter to cheer you, those who love near you, and all your hearts might desire. I love Snoopy. Anyway, yeah, so thanks so much for joining us. And if you guys have any other questions or concerns, or please feel free to let us know, and even write it into your evaluation, and anything we can do to answer more questions or help you be a little less hesitant to open up these conversations and just start them. You don't have to have them fill out the form, just have them start the conversation, because sometimes that's all they need, is just to start thinking about it. So thank you, everyone. And thank you, Karen, Dr. Lubomir, for sharing.